So thank you, Zapna, and thank you for all of you being here, and thanks to AIM and to MD Anderson for putting on this symposium. I think it's fantastic. So I was charged with giving you an update on surgical management of melanoma in 2013, and so I really wanted to not only cover basic surgical aspects, but also to bring you up to speed with kind of new applications on how we can use surgery in the really modern era and very exciting era where we're in with targeted therapy and immunotherapy. So in the next 20 minutes, I'll just give you quickly a little bit of a background. We already got a great background from Dr. Chan. I'll expand on that a little bit more. I'll talk about the role of surgery in early stage disease, and then also talk about the role in later stage disease. And then kind of a really exciting new area is talking about new roles for surgery in 2013. And then finally, I'll go over some summary and conclusions. And so just to get started into the background, I wanted to give you a little bit of information on melanoma. And you've heard some of this already, but basically melanoma is a major problem worldwide. The incidence is increasing. And as you see from this diagram, it's the 5th most common cancer in men and the 7th in women. And so it continues to be a real issue. But I wanted to kind of explain, what does a diagnosis of melanoma mean? Melanoma certainly is a potentially very aggressive form of skin cancer. It may arise in a mole, but it may crop up out of nowhere. And this shows a photograph of a melanoma that actually arose within a mole. Now, when someone develops a suspicious lesion like this, the first step is a biopsy. And so you undergo a biopsy, and then when a biopsy is performed, the lesion's analyzed under a microscope by a pathologist, and they characterize the lesion in several ways. Now, this is a lot of information, and I've included a sample pathology report here from one of my patients, but what I can tell you is there's really kind of 3 major things that we look at on this pathology report that kind of translate into how aggressive a melanoma is. By far and away, the most important thing about a melanoma is how thick it is. And you can see that, as it gets thicker, it's a much more aggressive melanoma. And then you can really get a lot of information primarily about this. But in addition to that, it's also important to know whether it's ulcerated, meaning that there's a little ulcer on top of the melanoma. It typically means that it's growing very quickly. And then this thing called mitoses, that basically means that when the pathologists actually look under the microscope at this melanoma, they actually see little cells dividing. And what that means is, again, it's rapidly dividing and potentially a more aggressive melanoma. Now, in addition, it's important to know, all those factors. But then, based on that, we can get the actual T stage of a melanoma. And I gave you a little chart here showing what that T stage is. Many of you will probably be somewhat familiar with that. But basically, T1 melanomas measure less than 1 millimeter in thickness. T2s measure 1 to 2. T3s measure 2.01 to 4, and then T4s are greater than 4 millimeters. These T1 lesions are the so-called thin melanomas. T4 are so-called thick melanomas. And then T2s and T3s are what we call intermediate thickness. And then they can further classify these melanomas based on the presence of ulceration into A, a less aggressive melanoma, or B, a more aggressive melanoma. And there's a little caveat that mitosis is used for those T1 melanomas. That's in addition. Anything, even if they see one cell dividing under the microscope, it puts it into that higher risk category. And it has some potentially important clinical implications. And so that's really what a diagnosis of melanoma means. Now, after someone's had a biopsy and we know their T stage, the next step is to determine the overall stage of a melanoma. It gets confusing because there's the T stage, there's the clinical stage, and I can tell you that the clinical stage is whether or not melanoma has spread anywhere else in the body. And so when we see patients, after a patient gets a biopsy, they're usually referred to either a medical oncologist or a surgical oncologist. And it's at that point that we do a physical exam to look for any potential signs of spread. And we may do other tests depending on how aggressive the melanoma is, and really purely on T-stage ulceration and mitotic rate. Now, I always say a picture's worth 1,000 words. You saw a diagram of the skin earlier where you see I've simplified it a little bit, as a surgeon here to a couple of layers. So there's an epidermis up at the top, there's a dermis below that, and then there's subcutaneous tissue, and beneath the subcutaneous tissue is muscle. And so that's on the upper left, that's normal skin, but you can see when we talk about the various clinical stages of melanomas, we'll go through this in detail. So there's a stage 0 melanoma, which is something called a melanoma in situ. It basically means that that melanoma is localized to the epidermis and has actually not invaded down past this thing called the basement membrane. And those are essentially precancerous lesions, and you can get a 100% cure rate if it's truly a melanoma in situ. When we talk about stage 1 melanomas, there it's actually broken through that little membrane and is either less than 1 millimeter, so it's either T1A or T1B, or it may be a slightly thicker melanoma, but with no ulceration. Stage 2, you get the T2 melanomas with ulceration, or if you have T2B or T4, don't get bogged down in this. But the important thing to remember is that, T1, or these stage 1 and stage 2 is very different from stage 3 and stage 4 in that stage 3 can be any melanoma that's traveled to the lymph nodes, and stage 4, again, is any melanoma that has spread to other parts of the body. And so for the purposes of this talk, we'll talk about early stage disease when I talk about surgery for this being these stage 1 and 2, and then later stage disease being stage 3 and 4. And so this slide shows the survival rates. We talked a little bit about this already by stage, and you can see that melanoma, certainly to no surprise to anyone in this room, is a pretty aggressive form of cancer. But I will highlight that with the advances that you'll hear about today over the next couple of hours, these survival rates are actually improving. So there's tremendous hope. So let me talk just a little bit about the surgical treatment for early stage disease. And really, when we do surgery for melanoma, so someone has a lesion, they get a biopsy, it's diagnosed as a melanoma, they come in and see me or a medical oncologist or someone else, and basically we have two main goals of surgery for early stage melanoma. First of these goals is to eradicate the melanoma and also reduce the risk of it coming back. So we not only remove the lesion, but we remove some tissue around it, and that's called a wide local excision. And then another important goal is to perform accurate staging in patients who have a risk for spread to lymph nodes, and that's something called a sentinel lymph node biopsy, and I'll go through all of these things for you. So this slide shows the technique for a wide local excision. Basically what we do is, you can see that there's a melanoma here. Based on the thickness, we measure a certain diameter around where that melanoma is to not only get the melanoma, but to get any potential cells at risk. And then we make skinny lips rather than a circle, just so that we can get the skin closed without the edges bunching up. That's really the only reason we do that. Sometimes we have to do a skin graft, in which case we leave it as a circle. And basically, the margins that we use are all based on the T stage. So if you have an in situ melanoma, we recommend 0.5. If it's a T1 or less than 1 millimeter, we go a centimeter outside of where that is. 1 to 2 millimeters, we go 1 or 2 centimeters. And then if it's over 2 millimeters, we go 2 centimeters. And so I just wanted to show you an example of a wide local excision. And so this is from a patient who had a melanoma on their shoulder. And so here you can see they've undergone an excisional biopsy. We've marked around where that melanoma was, and in all circumferentially, and then form a skinny lips, so that the skin will close without getting bunched up on the ends. And then once we actually excise that melanoma, or where the melanoma was, along with that margin all the way down to the muscle, and then close it, ideally primarily, but again, sometimes we have to perform skin grafts. Now, in early stage melanoma, we may also perform a sentinel lymph node biopsy. And we do this for melanomas that have sufficient risk for spreading to the lymph nodes. And in general, we do this on any melanoma that measures over 1 millimeter in thickness, so T2 or above. And then thin melanomas, that T1B category, so the thin melanomas that are either ulcerated or cells are dividing when the pathologists look under the microscope. And so the premise behind this technique, years ago, what we used to do is if someone came in with a melanoma on their arm, we would not only remove that melanoma, but remove every single lymph node from underneath the arm, and it was a pretty rough procedure, and most people didn't need it. Thankfully, now we've gone to the sentinel lymph node biopsy, where we do the following. So basically, 2 hours before, or a few hours before the surgery, you undergo an injection of that where the melanoma was with a radioactive dye. That then travels to the lymph nodes and highlights the so-called sentinel nodes. And then at the time of surgery, a couple hours later, I also inject a blue dye at the site of the melanoma, and then I use a gamma probe, which is a little Geiger counter essentially, to identify where the lymph node is and to take it out. And then I also use that blue dye to see it visually. And so this is a slide showing the technique. So this is, you can kind of imagine a body here. So this is the right arm, here's the left arm, here's the trunk, and here this person had a melanoma on their arm. This is where they injected the actual radioactive dye, and so you can see there's a lot of dye right at the site. That dye actually went through the lymphatics and went to these so-called sentinel nodes. Now, just because dye goes there doesn't mean there's melanoma there. It only means that those are the lymph nodes that drain the area, and those are the ones that we have to get. At the time of surgery, again, we also inject a blue dye, and then we use that fancy little Geiger counter, the gamma probe, to identify that lymph node through the skin before we make an incision, and then actually we make an incision over that site. And you can see that not only do we get this high count from the radioactivity, but we also can see the blue dye traveling into the lymph node, and the blue dye helps us identify that lymph node. And then our friends, the pathologists, do very important work. We actually take out the entire lymph node. We don't do frozen sections typically, meaning you don't have an answer right away, but usually takes a week or so to get the results back where they look under the microscope. This is actually normal lymph node all around, but then this is spread from melanoma right here and right here. And then they actually can use some special stains to highlight the melanoma. This brown stain shows where there's melanoma in a lymph node. And so now I'll just briefly touch on surgery for later stage disease. And so there are several circumstances in which we do surgery for later stage melanoma, and I'll go through a couple of examples. One is that we do surgery for melanoma that's spread to lymph nodes that drain the original site of disease. So go back to that prior example. Someone's had a sentinel node biopsy done. That lymph node shows melanoma. Then we want to do more surgery because there's a risk that the other lymph nodes could be involved. It's about a 15% risk. It's a discussion. It's standard of care as of 2013, but nonetheless, I think it's an important discussion to have, when you have a positive, what we call a positive sentinel node. And then the other scenario is when, someone's had a melanoma in the past, say on their leg, they come in a couple of years later and they say, I feel this lump in my groin. We do a little needle biopsy, sure enough, there's melanoma there. And then our task is to say, okay, is it anywhere else? So we do scans, and then if it's nowhere else, we can actually do surgery, and in many cases, which is curative in that scenario. Also, in many cases, not only in this circumstance, but when there's a positive sentinel node, additional therapy may be offered to help reduce the risk of it coming back, and Sapna will talk about that. So, another area of surgery that can be helpful in controlling melanoma that's spread is surgery for melanoma that's spread through the lymphatics, but it's localized to an extremity. Sometimes people will have a melanoma on the leg that goes through the lymphatics on their leg and hasn't gone anywhere else in the body, but they wind up with multiple little spots of melanoma on their leg. It's so-called in-transit disease. And what we can do for that is, we can actually isolate the vasculature to that leg and deliver high doses of chemotherapy and essentially control the melanoma just at that site. And then one final thing is that we can do surgery for melanoma that's spread to other areas in the body, and so what we call stage 4, metastatic melanoma. But it's typically most successful if you find only one spot and it's diagnosed a long time after the original melanoma was there. So I'll give you an example. I had a patient who 20 years ago had a melanoma on her arm. She came in and was having some stomach pain. She had a CAT scan and it showed melanoma actually in her pancreas. And we took out part of the pancreas. She's alive and well and doing fine. But in this new era, where we have such effective medical treatments, I think we kind of have to ask ourselves, what is the right role for surgery in that? And I think it's really complementary to treating the rest of the body as well. So, and I'll give some examples of that too. So in talking about, these lymph nodes, so these lymph nodes, we have many, many lymph nodes in our body. They're in the neck, in the armpit or axilla, they're in the groin, they're kind of all over our body. And when you have, say, a melanoma on the arm, it can actually travel to the lymph nodes underneath the arm. And these are kind of the most frequent sites where we will actually go and remove lymph nodes when we either see a melanoma in a sentinel node, or when someone comes in and they have, say, a lump in their neck or under their arm or in their groin. But kind of the most exciting thing that I wanted to talk about is some new roles for surgery in 2013. And the landscape for melanoma treatment is clearly changing for the better. So I wanted to talk about how we as surgeons can help patients and their families navigate this course, and along with a great multidisciplinary team to do what's absolutely right for every patient. And so I'll share with you a couple of scenarios, and then I'll also show you some case examples. And so I want to focus very briefly on the two areas. Those include the use of surgery to control areas of melanoma where other strategies are being used, such as treatment with targeted therapy or immunotherapy. That's kind of the first area that we'll tackle because it can be useful in this scenario. And then the other one is that surgery can be used to help understand why treatment is or is not working. And we do that mainly by looking at biopsies of tumors over the course of treatment. And so how do we help control melanoma through surgery when other strategies are being used? And I'm sure that most people in the room have heard about the huge success stories with regard to treatment for melanoma in the past few years through the use of targeted therapy and immunotherapy. And targeted therapy, basically, melanomas can have these little mutations which cause them to grow out of control and have multiple deleterious effects. And there are actually medicines that actually specifically target those mutations and can essentially shut the melanoma down. So pretty profound. And in addition, and you'll hear a lot more about this from Dr. Schnoll, immunotherapy can actually allow us, and also Dr. Hu, to capitalize on the power of the immune system here to actually have our own immune cells destroy the melanoma cells. So you'll hear a lot more about the success, but I wanted to show you kind of two representative examples of how effective these strategies can be. And so the first of these is with targeted therapy. And so this is a PET scan. So basically you can see this is a person who has all these black dots are melanoma. And so they have melanoma that's widely spread throughout their body. They get started on a BRAF inhibitor, which is this form of targeted therapy, take a pill twice a day, and within 2 weeks, most of those tumors have shrunk and are no longer visible on that PET scan. So pretty profound results. In addition, on the right, there's an impressive response to immunotherapy. And so immunotherapy, again, is how we kind of tweak the body's immune system to make it go out and fight tumors. And this is a patient who had multiple areas of melanoma throughout his body. I'm just showing you a few. He also had tumors in his lungs and his liver. And he actually had one of these tumors removed. They took that tumor out, chopped it up, grew up the immune cells, gave it back to him, and then his tumors completely went away and remain away. So there are successes. So why do we still need surgery, though? And so the bottom line is that even though these medicines are phenomenal and are very effective in many cases, they don't always get rid of the tumors. And so this is a case example that demonstrates that. And so this is a 64-year-old woman who was doing well until she developed some weakness and word-finding problems over the course of several months. And she underwent a CAT scan of her head in July of 2012, which showed a tumor in her brain. And so I'm just showing, this is a CAT scan here. You can see this is actually the skull. This is the normal brain here. And then this kind of area that's highlighted with the red circle, that's a big tumor that's sitting in her brain. And she had a CAT scan of the rest of her body, which showed tumors in multiple other areas. There were tumors in her chest, in her abdominal cavity, and there was actually a tumor sitting in her gallbladder. And because she was having so many symptoms from this tumor in her brain, she actually underwent surgery for that brain tumor. They took the brain tumor out. She recovered very well. And when the pathologists looked at the tumor under the microscope, they determined that it was indeed a melanoma. And so, in the era of all these, this exciting era where we can determine molecular mutations, her tumor was tested for mutations, and it was found to have a mutation in something called a BRAF gene, which, again, you'll hear more about. And she was started on this targeted therapy in August of 2012, just a few weeks after she had her brain tumor removed. She took a pill twice a day, did very well, had few side effects, a little bit of skin rash, some body aches. And then in January of 2013, she had some pain in her stomach and had a CAT scan done, which showed that actually most of her tumors had actually completely gone away, but there was a tumor in her gallbladder that actually grew, and it caused the gallbladder to be inflamed. And so I actually took out her gallbladder, and we looked at it, and it was resistant to the BRAF inhibitor, but she remains on it, and her other disease is totally controlled. So she's doing fine today. And so that's kind of an impressive case to highlight that. But there's another important role for surgery in 2013, and that's to help understand when treatment is or isn't working. And we can do this by performing biopsies during the course of treatment. So I've shown you an example of the dramatic response to targeted therapy, but each of these therapies has its drawbacks. Okay, so targeted therapy is phenomenal, no question. But there are some drawbacks. So though the majority of patients who get targeted therapy have their tumors shrink or go away, the effect isn't long-lasting in most patients. So for this one particular agent, most tumors come back within 6 months. Okay, so it has a timeline on it. And we're doing, over the past couple of years, we've been doing studies to understand why melanomas actually become resistant to this targeted therapy. And really, a lot of what we've learned has been by patients being kind enough and thoughtful enough to say, okay, I want you to do a biopsy so that I know what's going on in the tumor, and that even if it doesn't help me, it's going to help other people. And so we've been able to look at those tumors, do serial biopsies, and find out why the targeted therapy is or isn't working. And then immunotherapy has its drawbacks too, and so we sometimes see dramatic responses like the one I showed you, but it doesn't work in all patients. And we're doing studies to understand why some people respond, why others don't, and then also how are we learning this? By doing biopsies over the course of time. And we're also trying to understand why some tumors shrink but don't go away entirely. So just, again, I think case examples are a nice way to highlight this. This is a patient of mine who I just saw a couple days ago who's doing great. A 59-year-old man who had a mole on his leg in 2009, which became irregular in shape, started to bleed. He had a biopsy which showed melanoma, measured 2.4 millimeters. I won't quiz you on what T-stage, and it was ulcerated as well, okay? So he underwent a wide excision of the melanoma, had a sentinel node biopsy, and the melanoma had spread to 3 out of 4 lymph nodes. He had the rest of the nodes removed, and he was started on a medicine called interferon to try and help keep the melanoma from coming back. And he actually didn't have any signs of melanoma for a few years, but in 2011, the melanoma came back in his leg and also in other parts of his body, and his tumor was tested. And again, he had a mutation in the BRAF gene. It's sort of about half of melanomas. And so he was started on targeted therapy with this BRAF inhibitor in early 2012. His tumors got smaller on treatment, but they started to grow again after a few weeks. And as part of a clinical trial, he received another form of immunotherapy, which you'll hear more about, something called ipilimumab, and his tumors again got smaller. But he did have to stop the trial because his liver became inflamed. And he later went on a trial with 2 forms of targeted therapy, which again you'll hear more about later, and his tumors have now completely regressed and have not returned. Why do I show you this case? I show you this case because this is a case that we really learned a tremendous amount from by doing, he had multiple spots of tumor, he had multiple tumors on his leg. So at each point in therapy, we were able to do biopsies of these tumors, look under the microscope, and actually look from a genetic standpoint and say, okay, what's going on in these tumors? One focus of mine is to look at the role of the immune system in responses to these targeted therapies. And so I focused on looking at the immune cells in the tumors just to show you an example of this. And so I'll walk you through this. So before treatment, this is his tumor here, and the brown stain shows some immune cells. And before treatment, he really didn't have many immune cells. Well, we give him targeted therapy, and within 2 weeks, his tumors start melting away, and all of a sudden, all these immune cells rush into the tumor. But his tumors start growing again after a couple of weeks, and when we do the biopsy, we see that the immune cells are actually gone, nowhere to be found. So he got ipilimumab, which is immunotherapy, and the immune cells came back in full force and persisted for many months. And he actually is what we call a complete responder, meaning that all his tumors have regressed. So pretty impressive. So in conclusion, I think we can agree that melanoma can be a difficult type of cancer to treat, but there's been significant advances, and treatment options are much improved now. There's a big role for surgery in the treatment of melanoma with many ways to treat the disease, whether it's early stage or late disease. But a critical thing is that you really need to have a multidisciplinary approach for the treatment of melanoma, since the right treatment requires a team of practitioners and many different forms of treatment and support for patients and their families. So just want to acknowledge all the people in my lab, all the people at MGH, and all my new collaborators and colleagues, fellow faculty members at MD Anderson, and other mentors, and most of all the patients and their families for helping us study this. So, as I said, I've been at Mass General and Harvard for about 5 years after finishing up my surgical training. That took about 15 years. And then I am on my way down to MD Anderson to practice here. So it's a pleasure to be here. Thank you very much.